Hello, everyone. Welcome to this session titled Brains or Bytes in Search of Patterns. My name is Xavier García de Albeniz. I'm an epidemiologist in RTI Health Solutions, and I will be moderating this session with my colleague, Edward Lai. Edward, would you like to introduce yourself briefly?
Sure, thank you. Thank you. My name is Edward Lai from National Cheng Kung University. I'm the associate professor in the School of Pharmacy, and my focus is still on the pharmacoepidemiology. Thank you.
Thank you, Edward. As a reminder for the attendees, we are going to have 10 minutes presentation. After each presentation, we're going to have 5 minutes for questions and answers. If you have any questions, please write it in the chat box, and we will be addressing those questions after each talk. And if we have any spare time at the end of the session, we can use that time for additional questions or for reflections. With no further ado, let me introduce Monica Bertoya, who is a senior epidemiologist at Optum, and she's gonna speak about identifying active pregnancies using ICD-10 C3A codes versus completed pregnancy using outcomes. So the floor is yours, Monica.
All right, thank you. I'll share my screen. All right, now can everyone hear me and see the full slide screen?
Perfect, yes.
Great. All righty, so thank you for the introduction. Yes, so today I'll talk about using Z3A codes to identify active pregnancies versus identifying completed pregnancies in claims data using outcomes. And all co-authors are Optum employees, including myself. So to give a little background, pregnant women are often excluded from clinical trials, and drug safety during pregnancy is typically assessed through post-marketing studies such as pregnancy registries. Recently, administrative claims databases are becoming a more common data source for the evaluation of drug safety during pregnancy, often in parallel with a registry. And while registries can ascertain attributes such as the pregnancy start date, the pregnancy outcome directly from the patient, database studies have to infer this information based on claims patterns. And claims-based studies typically use codes to identify pregnancies, as well as patient characteristics and clinical events, but identifying distinct pregnancy episodes is challenging given that there's no codes identifying the start and the end of a pregnancy. And these dates are key for studying the effects of medication in pregnancy. So historically, claims-based studies use an average gestational period they assign based on the pregnancy outcome. So for example, full-term live births are assigned a gestational age of 39 weeks, stillbirths 28 weeks. And this approach works well for some outcomes, but it's associated with greater measurement error for others, like spontaneous abortions. And so we wanted to use ICD-10 Z3A codes here, denoting specific weeks of gestation, to see if we can reduce the measurement error associated with estimating pregnancy start date. So you can see here, for example, Z3A.12 is 12 weeks gestation. Code Z3A.13 is 13 weeks gestation, etc. And so our objectives here were to compare two methods of identifying pregnancies in a claims database. So the first method is an active pregnancy approach using Z3A codes. You can see those Z3A codes here in purple. We're expecting to see those throughout the course of a pregnancy. The second approach is a completed pregnancy approach using codes for pregnancy outcomes. You can see in green here, we're going to expect to see those codes at the end of a pregnancy. And we use the Optum Research Database for this work. This is a US-based claims database. We identified females of reproductive age between 12 and 55 years with commercial and pharmacy coverage on at least one day during the study period, which is essentially the ICD-10 era. So October 2015 through September 2020. So to get into the details of the first method, the active pregnancy approach, we started by identifying the beginning of pregnancies. And we identified that pregnancy start date, which we typically refer to as the LMP or last menstrual period. And we identified this pregnancy start date using Z3A codes. So for example, if a woman had a claim on July 10th with Z3A code 10, denoting 10 weeks gestation, we backdated to identify the pregnancy start date. So we backdated 10 weeks, yielding an estimated LMP or pregnancy start of May 1st. And often you'll expect many women are going to have multiple Z3A codes throughout the course of their pregnancy. In these situations, we identified all Z3A codes for a pregnancy. We estimated the LMP based on all Z3A codes, and we used the median LMP for that pregnancy as the start date. And there are some non-specific Z3A codes. We have a poster here at ICPE that walks into the utility of using those codes to estimate LMP. So something to keep in mind. I'm not going to talk about that here. And then using the active pregnancy approach, we identified the pregnancy outcome using pregnancy outcome codes, for example, codes for live births, codes for stillbirths, etc. And we assigned the pregnancy end date based on the service date of the claim containing those pregnancy outcome codes. The completed pregnancy approach essentially used the Hornbrook 2007 logic with some modifications. But this approach essentially starts by identifying the end of a pregnancy. So looking for codes, identifying a pregnancy outcome, live birth, stillbirth, etc. And this approach defines the pregnancy end date. You know, we're using the same outcome code list here, the same logic to identify the end date or the date of that pregnancy outcome. One of the main differences here is how we estimated the LMP. And so with this completed pregnancy approach, we used the outcome type and date, and then assigned that gestational period to backdate and get the estimated LMP. So for example, we assumed all full-term singleton live births had 39 weeks gestation, a little bit shorter gestation for multiples, 28 weeks for stillbirths, 10 for abortions, 8 for molar and ectopic pregnancies. And so looking at the top here, we identified over 10 million females of reproductive age. Among those females, we identified close to 900,000 pregnancies using the active pregnancy approach, and a little over 800,000 using the completed pregnancy approach. And given that this completed approach relies on seeing evidence of a pregnancy outcome to identify pregnancies, it's no surprise that all of these completed pregnancies had a known pregnancy outcome. On the other hand, you can see here that 209,000 of the active pregnancies had an unknown outcome. And this isn't unexpected, given that we're looking for pregnancies starting from the very beginning, Z3A codes that are occurring early on in pregnancy, we might expect some pregnancies that start close to the end of the study period are going to be ongoing at the time of the data pull. But actually, you know, this is quite a few pregnancies, more than we would have expected due to that reason alone. So we looked into this, and actually most of these, 81%, had an unknown outcome because the woman disenrolled during pregnancy. And you can imagine, we're expecting a lot of pregnancies are going to be identified by both methods. So when we deduplicated, we ended up with over 1 million unique pregnancies. 677,000 of these were identified by both methods, so most. However, over 200,000 were identified by the active approach only, and about 145,000 by the completed approach only. And, you may be thinking here we had about 4,600 active approach pregnancies that were not identified by the completed pregnancy method, but they did have an observed outcome. And so this is, a little bit counterintuitive, but really, even though we're using the same outcome code lists for both methods, there is some difference in the logic I didn't get into on identifying distinct pregnancy episodes. And so that explains this slight discrepancy. This is, 4,000 out of over 1 million pregnancies, so it's less than 1% of pregnancies. And so in conclusion, while most pregnancies were identified by both methods, a substantial number were identified by only one method, and each approach has its own strengths and limitations. For example, one strength of the active approach is it has potentially more accurate estimation of LMP using those granular Z3A codes. And it's important to estimate LMP as accurately as we can when we're looking at drug exposures, during pregnancy, during the first trimester, et cetera. Another, for example, strength of the completed pregnancy approach is that those Hornbrook algorithms have been validated with medical records and performed well for many outcomes. So our take-home message is that an optimal approach is probably going to be a hybrid of the two methods. And we're looking further into those active pregnancies that don't have a pregnancy outcome observed, as well as some completed pregnancies that don't have Z3A codes during the ICD-10 era. So thank you. Looking forward to questions.
Thank you very much, Monica. I don't see any question in the chat box. I can see an attendee raise her hand. I don't know if she wants to make any questions. Okay, maybe people need a little more time to come up with questions. So let's move to the next. Wait.
I thought there's one question
Sasha?
from the. I thought there's a question from.
Go ahead.
Sorry, I found there's a question from the QA screen. If one question from Amir Sarayani. He asked if they observed only one Z3A code with no outcome, did you consider it an actual episode?
We did, and that's a good question. So that would be another good area for exploration, and maybe for validation to look to medical records to see, are these true pregnancies if it's just that one Z3A code? Yeah, great question. So I know my colleague Andrea Komistek, she presented on some validation results for these, the algorithms we use to estimate LMP using Z3A codes, and those, the validation results were good, but they did not look at that question specifically, which is a really interesting question.
Can you hear me?
Yes, we can. Go ahead.
Fabulous. This is Sasha Devlin from Kaiser Permanente, Washington. First, I just want to commend you. I think this is really, really exciting and important work. I have two comments. I'll try to keep them really short, and a question. I think the major importance of this to me is really, as we think about causal inference and emulating a target trial, our ideal really is to identify women who are pregnant before their outcome and follow them forward. And we've had vigorous debate in one of my studies about hypertension and pregnancy about how wrong it was to start with the endpoint and then work backwards. So I really encourage you to keep pushing this forward. My other comment would be just a quick shout out for the really crucial importance of chart review. If you're ever able to get and read any of these women's charts, you will really get insights into what happened. And my question is, what do you know about the women who you found through the outcomes who weren't found through active pregnancy codes? Because it makes me really wonder, are we not maybe observing their prenatal care, or, you know, would we get in trouble if we included them into a study? What do you know about them? Thank you.
Yeah, that's a great question. Thank you, Sasha. So it's so you're asking about the pregnancies that are identified by the completed approach only. So there's evidence of the pregnancy outcome, but no Z3A codes, right?
Yes, exactly.
Yes. Yeah, and so we were thinking, you know, we looked in this a little bit, but we have plans to look more deeply. But some of them are just pregnancies that happen to end right after the U.S. transitioned to ICD-10, and so they just didn't have really as much of an opportunity to get a Z3A code. But, you know, that's not true for most of them. Most of them are, you know, occurring much later in the study period. So we're looking into those because we're curious, maybe that pattern of not having a Z3A code in the ICD-10 area is associated with certain types of pregnancy outcomes. And we would like to validate at some point if we can. So we'll definitely try to do that if possible. Yeah, because I think even looking at just a few records would give us probably give us information we didn't even know to look for.
Great, thank you.
That's a great point too from Amir, that, you know, maybe some of those women, you know, just like we saw those women who disenrolled midway through pregnancy, you're right. Some of those women without Z3A codes who have an outcome may have enrolled during pregnancy, and so they had less of an opportunity for Z3A codes. Thank you. Yeah, and women, thank you, Sasha, has another comment. Women can be enrolled in a commercial insure and Medicaid at the same time. So that's also possible that we're missing some of those information flows.
Okay, thank you for all the audience for the questions. Thank you, Monica, for your excellent presentation and addressing the questions. I think we can move to the next presentation. The presenter is Ella Jansen, a researcher at Pharmo, and she will present a prediction algorithm for identifying patients with Fabry or Pompe disease in electronic health records. So Ella, you can go ahead.
I think you can all see my slides now.
Yes.
Perfect. Okay, thank you so much to ISPE for letting us present on prediction algorithms for identifying rare disease patients in electronic health records. In this presentation, I will focus on the case of Fabry disease and shall explain our process of developing a prediction algorithm step by step. So these are the disclosures of the contributing authors. But first, a little bit of background. So what is Fabry disease? Well, Fabry is a rare disease that usually has its onset during childhood or puberty. It is a progressive hereditary lysosomal storage disorder where the lysosomes are not functioning properly, which results in an accumulation of a large molecule, GL3, which damages the cell, and that gets worse over time. And when GL3 accumulates, this results in many different symptoms that you can see on the right of the screen. It ranges from headache to a tingling or painful feeling of the hands and feet, but also typical red dots on the skin called angiokeratoma are seen. However, because some of the symptoms are so general and common, clinicians often do not think about Fabry at first instance, meaning patients are not treated and the disease gets the time to progress and develop even more serious symptoms like kidney failure and heart failure, which can be fatal. However, as I said, if they are not treated, but luckily treatment is available in the form of enzyme replacement therapy, which can slow disease progression. Hence, it is vital that Fabry is recognized timely and treated accordingly before it progresses into the more serious health conditions. However, it often takes years before a patient is correctly diagnosed after having seen numerous specialists, which is a common problem for many rare diseases. So that immediately provides us the answer on the why of this research project. Why trying to develop a prediction algorithm that identifies potential rare disease patients? Well, because through earlier diagnosis and early start of treatment, unnecessary and often irreversible health loss can be prevented in patients that have an unmet medical need. However, we do want to highlight that we don't just want to put a label on someone, but on purpose picked Fabry disease for which there is a treatment available. So the objective of this study is to detect patients early in clinical practice that are likely to be at risk of Fabry, first through the development of a prediction algorithm, and then through the deployment of that algorithm in clinical practice, where GPs participating in this project shall be notified whether they have a potential patient in their catchment area for whom further consultation may be warranted. All right, but how to then ensure early detection of disease and correct diagnosing? From here on, it's going to be quite a technical story, but the basic idea is straightforward. We teach or train the algorithm to detect Fabry disease by providing it with examples of patients who have Fabry and patients who don't. And these examples are the so-called training sets. All right, then how did we construct that? Well, from our PharmaGP database that includes anonymized electronic health records, or EHRs, stemming from GP practices of about 3.2 million residents of the Netherlands, we selected 3 small cohorts to be the training sets. And what's good to know is that our GP database is actually an anonymized copy of the non-anonymized GP database of a data warehouse from a trusted third party that anonymizes and stores the data for us, which we shall later need to implement the finished algorithm in daily practice, but I'll come back to that later. However, to stay in line with the GDPR, the algorithm was built on anonymous data. Okay, so to yield the training sets, a clinical profile of Fabry disease had to be created. And this created profile was based on an algorithm that reads PubMed and transforms each medical concept, such as diagnosis code, medication, lab results, symptoms, etc., into a mathematical representation, which shall indicate what the most Fabry-related concepts are, according to existing medical knowledge captured in the literature. So as you can see from the 40 million abstract that were screened, the 50 most relevant Fabry-related concepts were determined, on which basis the clinical profile was created. And from this, disease-specific queries were produced that were run over the GP database to make the small and specific training sets that match the clinical profile that we're looking for. And this is what you see depicted here. So the first training set included patients whose clinical presentation matches the clinical profile well. So patients that have or would be likely to have Fabry based on the mentionings in their EHR. Then the second group, the second training set, included patients that mimic Fabry, but likely aren't the patients that we're looking for. And so these 2 training sets are thus very similar, but the difference is that patients with a confirmed diagnosis of another disease, such as Guillain-Barré syndrome, were put in the second training set, the mimic group, and only confirmed or potential Fabry patients were included in the first training set. And then finally, the last subset to train a disease finding model was a random sample of patients that were not included in the previous 2 sets, and that matched the first one on the basis of age, gender, and date of earliest records. We then extracted the EHRs of these patients, and then through a combination of both supervised and unsupervised machine learning, we induced a patient finding model from the training sets. Then from the application of that model on the PharmaGP database, a pre-specified number of patients based on high predicted probability of having Fabry were yielded, and the EHRs of these patients are shared with an involved specialist that serve to validate the found or the selected patients. And so this slide is just to show you how the cutoff point for the green group is. The green group is the mimic group, and the red group is are the random patients. And so you see that the curve is actually quite steep, meaning that the cutoff point could even be put at a lower probability, like 0.5, but that this wouldn't necessarily yield many more patients, which is what you want, because this disease is rare, so you wouldn't expect to find too many patients anyway. Then why the 0.6, not 0.5? Well, because we also don't want to overburden the specialist that needs to validate the found patients. Okay, so then going back, Again, from the application of the model on the GP database, a number of patients were selected. In total, 28 patients that were marked as likely of Fabry. And the specialist, the involved specialist, in fact, listed 27 of these patients as indeed likely of Fabry and one as possible Fabry patients. Moreover, of those 28 patients found through the patient finding model, 12 patients were already on Fabry medication and are thus confirmed cases, but more than half were newly found potential patients, or at least patients who were not yet treated for Fabry. So there's some very exciting and promising results. These results of the specialist chart review will then be further used to refine the patient model again and further detect any potential candidate patients. Moreover, from this round of validation, it should also become more clear what some of the highest predictive variables may be. And these can be pre-processed on the EHRs of the candidate patients, which will yield a data matrix where a 1 represents the presence of a predictive variable and a 0 the absence of this. Okay, so all in all, we now have a pre-processing code to obtain a data matrix and a trained patient finding model, which are needed to identify the patients. However, as I mentioned, so far this was all developed on anonymous data, and thus we wouldn't know who these high potential candidate patients actually are. So therefore, deploying the algorithm in daily practice on data from a non-anonymous copy of the GP database of that trusted third party that I earlier talked about would be the next step in the process. However, as this is not in the scope of this presentation, I will not go into too much detail of the deployment process, but essentially this is what we will do as a next step. So in that process, GPs first have to authorize that trusted third party who has signed a non-disclosure statement to use the data from their GP practice. Then upon deployment of the algorithm on the data from that GP practice, the GPs will be notified through an online portal whether they have a patient in their catchment area that was marked by the algorithm and that they can invite for further consultation. But for now, to conclude, we are still in the process of algorithm development. However, the first results after chart review by the Fabry specialist show some very promising results. And this really excites us to further work out a similar algorithm for Pompe disease and hopefully in the future also for other rare diseases. And we believe that through this collaboration, we hold a unique opportunity to not only identify potential rare disease patients, but also notify their GPs on this, through which hopefully diagnosis can become more timely, treatment can be started early, and health loss can be reduced. Thank you very much for your attention. If you have any questions, I'm happy to take them on.
Thank you very much, Ella. I don't see any questions in my chat box. If nobody has any questions, I'll go ahead and ask you a question. It's a very interesting approach. It's great that you apply it to a rare disease. What would happen if you apply it to a more common disease that has a development phase, like cancer, for example? How would that affect your predictive values, something that is more prevalent?
Mm-hmm. Well, I think what's really unique indeed about this approach, and very specific as well for rare diseases, is that it was trained on both sort of the potential target population group and a group that really mimics it. And that's because there is no ideal situation. In an ideal situation, for instance, for something that is very prevalent, like diabetes, you wouldn't need to build an algorithm on non-ideal training sets, because you would have a lot of sort of perfect examples in a potential training set. So I think it really depends on what type of disease you're looking at, that you're looking for. We believe that for rare diseases, this is a good method to go forward and create an algorithm to identify these patients based on maybe less ideal data or not confirmed cases. In the case of cancer that you're particularly referring to, I think then it really depends indeed what type of cancer it is. If it's a rare cancer, you could possibly look into this. If it's a non-rare cancer, I don't think that creating training sets based on or the way we did it with mimics and stuff is the way forward, because then you could probably just use an easier approach. But I think this methodology could be very useful and interesting to explore for other rare diseases as well. Yeah.
Thank you very much for your answer. So if we don't have more questions, we'll go to the next presentation. The next presenter is Jin-Soon Jin, a researcher from the Brigham and Women's Hospital in Boston. And she's going to talk about the impact of longitudinal data completeness of electronic health record data on prognostic risk score misclassification. So Jin-Soon, the floor is yours.
Thank you. Thank you for your introduction. Can you hear me clearly?
Yep, perfect.
Okay, perfect. Hi, everyone. It is my pleasure to share our recent work evaluating the impact of longitudinal data completeness of electronic health record data on risk score misclassification. The study was funded by NIH, and here's the disclosure statement for our study team. So let's get started with some background and aims of the study. So we all know that there has been a remarkable growth in comparative effectiveness research that using EHR as the primary data source. This is due to the unique strengths of EHR data compared to widely used claims insurance data in the US. Unlike claims data, EHR data contains some rich clinical information, such as like body mass index, blood pressure or lab test result, etc. However, there is one key limitation of EHR data in CR studies, which is EHR discontinuity. So we defined EHR discontinuity as receiving care outside of the reach of the study EHR. Since most EHR systems in the US do not capture all medical encounters across all care settings for the patients, using EHR data alone may miss a substantial amount of information of the study population. So while one possible solution is to link the EHR data to some other data source like insurance claims data, but such linkage is often not feasible. So we previously came up with a prediction model to identify patients with high EHR data continuity with the predictors that are available in typical EHR system. This table here shows the predictors and their coefficient that were used to calculate a patient's predicted EHR continuity. We used some key variables that are that represents patients' routine care, preventive interventions, and some diagnosis or medications that are received in the EHR system. Using this algorithm, we evaluated misclassification of 40 individual variables that are commonly used in CR studies. We found that patients who had top quintile of predicted EHR continuity had 3.5 to 5.8 folds of less misclassification of, compared to those in the lower quintiles of the predicted EHR continuity. So in addition to individual clinical variables, risk scores are useful ways to summarize certain underlying risks of the study population in CER studies. However, it is not yet studied how EHR continuity may impact some risk scores and phenotyping algorithms that are widely used in CER studies. So we hypothesized that patients with low EHR continuity would be misclassified with lower risk scores based on only EHR data as compared to that using the linked EHR plus claims data. We selected 4 commonly used risk scores to test our hypothesis, CHAS-VASc score and HAS-BLAS scores. which are used to assess the risk of stroke and bleeding among atrial fibrillation patients, and combined comorbidity score, which combines 20 elements of the Charlson Index and the Alex-Oster system to summarize patients' comorbid conditions. And lastly, the claim-based frailty index, which is used as a predictor of various adverse clinical endpoints among elderly population. So now let's go through the methods. We used Medicare Parts A, B, and D claims data linked to 2 EHR systems from 2007 to 2017. So previously in our EHR continuity prediction model study, system 1 was used as a testing set and system 2 as the validation set. Both EHR systems include care facility across all care continuum. And our study population was individuals in the linked data who aged at least 65 years old, with minimum of 1 year continuous enrollment in the Medicare, plus at least 1 EHR encounter during the active Medicare enrollment period. And study index date was the first date when all these criteria were met. And since chest vasc and the Hess blood are used for the stroke and bleeding risk assessment only among atrial fibrillation, so for these two score misclassification assessment, we further restricted study population to those non-valvular AFib patients. Then we measured risk score components between 1 year prior to and on the index date. The same variables were measured twice. One set using EHR plus claims data and another set using only EHR data. And risk scores calculated by variables measured from EHR plus claims data were used as our gold standard. And this was compared to those calculated using variables from EHR data only. So to quantify the impact of EHR continuity on misclassification, we divided patients into deciles of predicted EHR continuity. And within each decile, we calculate the mean risk scores based on EHR plus claims and based on EHR only. Then calculate the mean standardized difference weighted by the number of patients in each strata. Additionally, we conducted a trend test for the misclassification across the predicted EHR continuity. So in addition to the mean risk score, we also calculate the number of patients who were misclassified by more than 1 or more than 2 categories of risk score using EHR data only compared to using EHR plus claims. So for example, if a patient's chest vasc score was 5 using EHR claims versus 3 using EHR data only, then this defined as having misclassification of 2 categories of chest vasc risk score. Again, all the misclassification were assessed within each EHR continuity deciles, then a trend test was conducted. Here are our results. We'll begin with selected patients' characteristics. We included over 133,000 individuals with mean age of 73 and 74 in EHR System 1 and System 2. Using EHR plus claims data, you can see that we were able to capture substantially more comorbidities, which are the components of study risk score. And this led to the mean standardized difference of risk scores ranging from 30 to 93%. And this figure shows the weighted standardized mean difference of risk scores between EHR only and EHR plus claims data by deciles of predicted EHR continuity. The left figure presents the results from EHR System 1, and the right figure presents results from EHR System 2. So in both figures, x-axis is the deciles of predicted EHR continuity, where 1 is the lowest and 10 is the highest. And y-axis is the amount of weighted standardized mean difference in percentage. So in the figure, different colors represents for different risk scores. And as you may find from the figure, the trend of decreasing amount of misclassification with increasing EHR continuity is consistent for all 4 risk scores in both EHR system, and the p-values were statistically significant. And this figure shows the proportion of patients with misclassification of at least 1 category of risk score by deciles of predicted EHR continuity. And again, the x-axis is the predicted EHR continuity, and the y-axis stands for the proportion of patients with at least one category of risk score misclassification. And we observed a similar trend of decreasing misclassification with increasing EHR continuity, and the trend test p-values were all statistically significant. And when we measured the misclassification of more than 2 categories of risk score by deciles, we consistently observed the similar patterns. So the study results have some important implications. For example, among AFib patients, CHA2DS2-VASc score greater than or equal to 2 are considered as eligible for an anticoagulant treatment. And those with CHA2DS2-VASc score greater than or equal to 5 are considered to have high risk for preoperative thromboembolism. So in our study patients, among the lowest decile of EHR continuity, we captured only 1% using EHR only, and 38% using EHR claims data for who were eligible for anticoagulant treatment. But when we restrict patients to the highest EHR continuity decile, the proportion was 29 in EHR only versus 36 in EHR plus claims data. Similarly, for HAS-BLAST score, AFib patients who are considered to have a high risk of bleeding, which is score greater than or equal to 4, were only 1% using EHR versus 41% using EHR plus claims data in the lowest EHR continuity decile. But in the highest EHR continuity decile, the difference becomes minimal, which is 46% using EHR only versus 53 using EHR plus claims. And in terms of combined comorbidity score and frailty index, the weighted standardized mean difference was up to 93% and 125%, but this amount decreased to 3% and 8% in the highest EHR continuity decile. So there are several limitations should be taken into consideration. Although we quantified the misclassification of risk scores in this study, the ultimate impact of such misclassification on a causal effect assessment of a severe study would rely on testing in a wide variety of empirical studies. And restricting study cohort to high EHR continuity patients would inevitably reduce the cohort size and the statistical power. And lastly, our study was conducted in Medicare patients linked to 2 large EHR system data in the US. So the generalizability of study results needs to be tested in different EHR systems and age groups. So in conclusion, restricting the CR study cohort to those with high EHR continuity would reduce misclassification of key risk scores, but further studies are in need to estimate the actual amount of bias caused by such misclassification of risk scores. So thank you for your attendance, and I'd like to take any questions you may have.
Thank you. Thank you very much, Jinsu. I don't see any questions from the audience. I don't have any questions myself. Edward, do you have any question?
Oh, yes, maybe I can ask one question about, you suggest that maybe we can exclude or restrict the patient with high continuity, EHR continuity patient. Is that possible to introduce some bias, for example, selection bias, because they may have like a trend?
Right.
Yeah.
Yeah. Yeah, that's a great question. So we also thought about losing the representativeness of the patients after we excluding some low EHR continuity patients. But then we actually went back and compared the several comorbidities of patients among those within the lower side of the EHR continuity versus high EHR continuity, but they were the same based on the EHR plus claims data. So which means obviously if we only use the EHR data, that will contain capture less comorbidity. But if we compare those two groups using both EHR plus claims data, the comorbidities were captured similarly. Does that answer your question?
Yes, thank you very much.
No problem.
So Shabia, should we move to the next speaker?
Yes, yes, please.
Okay, thank you. So let me welcome the next speaker, Tajis Ramazanian. The topic is leverage AI technologies for automatic identification of TKA device in electronic health record. Please.
Okay. Can you hear me?
Yes, very well.
Okay. Let me see. Okay. I'm just trying to bring this one out of. Okay. Hello. Hello, everyone. Yeah, my name is Tagi Ramazanian. I'm an orthopedic surgeon, Mayo Clinic, and on behalf of my
Tagi, sorry, you might switch the display settings. There, because we see two screens.
Oh,
there's
sorry.
So there's an option, the display settings, so you can switch the panel.
Okay. You see two screens now? Okay.
Yeah,
If you go up to display settings,
display
click the
settings.
down arrow. Yeah. Swap the presenter view.
Sorry, I don't see the display setting here.
You have to move your mouse to the
Up a little
top
higher.
of your screen. Yeah, a
Yeah,
little higher.
Here, this is the mute.
Nope. Up.
Oh, sorry, I don't see.
It's at the top of your PowerPoint on your speaker notes slide. Toward the left-hand side as you're looking at it, it says display settings.
Can you see my mouse now?
Yes, I can. If you move your mouse up.
Okay, up.
Up a little more.
Okay.
Do you see display settings?
No, actually I just see the mute, stop videos, and show taskbar.
So next to show taskbar should be display settings. We can see it on our screen.
Unfortunately, I don't see it. Let me, sorry. Let
if that is the case, I think.
see. Let me stop sharing and sorry, I'm so sorry. So let me share again and choose, okay, one screen number 2, what's that, number 1? Okay, let's see, how does it look like now? Is it better now or is it the same?
You can just present from here in the essence of time, since we don't have a lot of extra time.
Okay, sorry.
Please go ahead.
On behalf of my co-authors from Mayo Clinic, today I'll present our research with use of AI technologies for identification of different types of knee implants in electronic health records using both computer vision and natural language processing technologies. Our studies are funded by the NIH. So here you can see a little bit of background of progression of knee osteoarthritis. This knee X-rays shows the disease process that leads to knee arthroplasty. Figure A is a front view or AP view of a normal knee, normal healthy knee. As you can see, there's a space between femur and tibia here, which is filled with cartilage and it's radiolucent. It means that we cannot see it in an X-ray. Figure B actually shows a knee with severe arthritis, and you can see the joint space is lost. And in this stage of the disease, patients have severe pain that impairs their daily activity. And then figure C shows an X-ray where both knees, right and left, are replaced by knee implants. It's worth noting that knee arthroplasty is the most common inpatient surgical procedures in the United States and around the world. Over 700,000 procedures are performed each year, and nearly 5 million Americans are currently living with knee implants. Although knee arthroplasty is a very effective surgery, some patients need revision surgery due to various complications. When we decide to do a revision surgery, we as an orthopedic surgeon actually prepare ourselves for a complex surgery. A critical part of the preoperative planning is identifying previously used implants, and this is not an easy task. And apart from clinical care, implant identification is essential for device surveillance and reporting. Unfortunately, UDI are typically not available in structured format in either the electronic health records or claims data. So where to look for? Implants information may reside in hospital operative notes, implant sheets, supply chain records, etc. And if it's easy, it's not. It's a time-consuming and sometimes frustrating process. About 10% of implants couldn't be identified before surgery, and 2% couldn't be identified even during the revision surgery. So with this background, our goal was to develop automated tools for identification of different types of implants in electronic health records using both computer vision and NLP approaches. In our computer vision approach, we used 9,000 knee x-rays from 3,900 patients with 4 different types of knee implants. And in our NLP approach, we used operative notes of about 1,500 patients, identify implant catalog numbers for 6,800 implants, and map them to corresponding UDI numbers. So I start with computer vision model that we use on knee x-rays. So upper part of this slide, as you can see, figure A shows some examples of the x-ray with knee implant, as you can see, front views and side views. And the lower part of the slide shows an outline of computer vision model and its pipeline. We fed all the knee images to the model, and the region of the interest, as you can see, shown by green box, around the knee is extracted by the model as a bounding box containing the implants, and then this output is running through the model for identification of 4 different implants type, as you can see on the right side of the lower part of the image. Here is the performance of our computer vision model in comparisons to other commonly used deep learning image recognition models like Inception, ResNet, DesNet, etc. So as you can see, while precision or positive predictive value for other models were between 77 to 91%, our model had a precision of 96 to 98%. For recall or sensitivity, other models had recall between 34 to 96%, while our model showed a sensitivity of 94 to 99%. Similarly, the F1 score and overall accuracy of the model was high, and the model had almost perfect performance in classifying these 4 knee implants. Sometimes we hear that the AI is a black box and we don't know what's happening inside the model. This figure actually shows the saliency map of the images and what areas of the images are looked at by model to classify implants. As you can see in front and side views, model is looking for specific features of each implant to categorize it in one of the 4 categories. Now I'm moving to NLP methods for implant identification. So this slide shows the workflow of our NLP algorithms to detect total knee implants in operative notes. So first we retrieve operative notes from the EHR. Next, we use text processing for generic NLP, such as sentence segmentation, sectionization, and assertion, as a pre-processing step to apply expert-based rules. And next, we use specific rules to detect catalog numbers and implant descriptions. And then we finally compared system output with gold standard data from our institutional joint registry. To implement the NLP algorithm, we used MedTagger, which is an open source information extraction NLP tool specialized for the clinical domains. And this slide shows the performance of the NLP algorithms in detecting 6,800 implants and mapping them to UDI numbers from almost 1,600 operative nodes. So as you can see, NLP algorithms detected 6,809 catalog numbers that were in operative nodes and 12 catalog numbers that were not in operative nodes. 4 operative nodes didn't contain the catalog numbers, and also only 4 catalog numbers were not detected by the NLP algorithm because they were entered in unusual format within the operative nodes. So the main challenge was to eliminate invalid number detected by the NLP. NLP algorithm had perfect performance as shown with the sensitivity, precision, and F1 scores almost 100. So in conclusion, both computer vision and NLP algorithms can be used to identify specific implants in electronic health records. And these findings illustrate the potential of electronic health records and AI technologies for device surveillance. And both studies are published, and these are the references to the papers. And thank you for your attention. I'm open to question now.
Thank you very much for a very nice presentation. So I think we have 3 minutes for a couple questions. Is there any question from the floor? If no, can I ask one question about, would you suggest that to do like a both methods, computer vision and also NLP approach to improve the identification in the same time?
Yeah, are you asking me to using like a combination of both of those?
Yes, that's right.
I think so, yeah. Yeah, we think that it's actually kind of this fusion model would give us a better accuracy.
Okay, thank you. And I see David Carrera, please unmute and go ahead, your question.
Thank you. Yeah, really interesting presentation, Tahi. And I thought it's very clever that you used NLP to go after the serial numbers or the model numbers of these devices. And I think that represents one of the tactics in NLP to try to find the easiest way to capture what it is you're trying to get. My question is, before you got into this, had you considered that maybe other approach, maybe you'd have to find descriptions of the devices rather than numbers that correspond to the model numbers?
Description of the devices?
Yeah, it's like more generic things like, description of the implant procedure or something like that, rather than actually going off after a model number. I'm just curious if there were other types of information that you originally thought you might have to try to capture using NLP.
Yeah, I mean, maybe I'm not the right person to answer this question because I'm an orthopedic surgeon working with a team of the computer scientists. But my understanding is that that was the best in terms of the accuracy, because when we're going through the operative notes and looking at the implants type, and then there might be I wouldn't say lots, but some overlap between type of the prosthesis from one brand. So
yeah, no, it seems like it's a very clever approach. Really interesting. Thank you.
Sure.
And I saw there's one question from Soko Setaguchi. Did you make any customizations to the mate tagger programs for this, or is it a self program? And is the program also taking a partial string match and giving you the probability of match?
This is, as I mentioned before, I am not familiar with the details of the NLP approaches because, as I mentioned, I'm an orthopedic surgeon.
Okay.
But what we did actually is that we use gold standard, and we also kind of check points in some of our results with an orthopedic surgeons. You know, checking the operative notes.
Okay. Okay, thank you. So I think it's time. So let me move to the next speaker. So the next speaker is David Carrillo. The topic is improving methods for identification anaphylaxis for medical product safety surveillance using NLP and machine learning. Thank you.
Thank you. And let's see, I'm going to put my, are you seeing my slides?
Yes, very well. Thank you.
Great. And let's get the pointer here. Okay, great. It's a pleasure to be able to present alongside all of you today. The work I'm presenting is currently under review, and so there's lots of details in the paper. There's a 100-page appendix that goes with it, so I'm going to give you a high-level overview, and if you're interested, I'll refer you to the paper that hopefully will be out soon. I'm going to talk about the motivation and objectives. I'll go over the study design and then talk about the results. First, our motivation. This work is funded by the FDA Sentinel that has the active risk identification and analysis system that's designed to allow Sentinel to conduct post-market safety surveillance for products after they've been approved. And it relies on structured data largely from claims data from over 100 million patients, but often the structured data themselves are inaccurate or imprecise enough to conduct those analyses. And so improving those ARIA capabilities is what motivates this work. In the context of anaphylaxis, where we looked at, which is an important outcome for Sentinel, existing algorithms, they rely on structured data, they have good sensitivity, but they lack positive predictive value. And this is not surprising given that it's a challenging outcome to model. It's rare. They're often rule-out codes that confuse the data. It's a complex diagnosis. Some work by Ball and colleagues suggested, however, that NLP may be able to capture some information and notes that would help more accurately identify the true anaphylaxis cases. And that's what we did. So we're using NLP extracted data to enrich the covariate sets for modeling. And then we're using machine learning as a way to better model the signal that are in those rich data. This is a quick overview of the study. It was we used data from 2015 to 2018. Patients came from 2 healthcare systems. Kaiser Washington was where we developed the model, and Kaiser Northwest, excuse me. Kaiser Northwest is where we validated the model. All the events included had to have at least one anaphylaxis diagnosis code. And in order to ensure that EHR continuity that Ian Zhu talked about, we required 12 months of prior enrollment and no anaphylaxis diagnosis during that time so that we were getting new presentations. We created gold standard, and as I'll talk about in the next slides, created several covariates. First, I won't go into too much about our sampling. Though we identify people, the lighter blue circle represents those that have an anaphylaxis code. The lightest blue circle are those codes appearing in inpatient or ED settings. And then we sampled separately from them with a stratified approach. Our gold standard creation was created by manual review at Washington by clinicians and at Northwest by chart abstractors overseen by clinicians. This manual process of developing the NLP system, which is similar to what Tahi was showing us in the most recent presentation involve clinicians and informaticists reviewing charts. Here's some examples of charts. In the top, we see, the concept of swelling is important for this diagnosis, the concept of erythema. Sometimes we would find sections of text like this lower example here, where lots of relevant symptoms are described in the context of maybe a description of a diagnosis, some treatment, and so forth. And so we actually also operationalized some covariates to try to indicate when this really dense presentation of information relevant to anaphylaxis was appearing in the notes. And then we used, we operationalized those variables that we felt were most relevant. The structured data covariates we operationalized there were 43 of them: demographics, the cause of anaphylaxis, presentation setting, and so forth. Now on to the NLP work. As you know, NLP is a process of converting this unstructured text into structured data so it can be modeled. In terms of the brains versus bytes theme of this panel, we used a brains approach. Our NLP was guided by manual curation. But I also want to mention that a very much more bytes focused approach has been described in the literature and may also be useful approaches. And we're looking into some of those now in some work that has followed up on the work that I'm presenting today. Here's a schematic of an overview of the NLP process. It requires gathering the text into a corpus, creating the gold standard, and then this process over here of identifying dictionary terms, algorithms to represent the various features that might be useful for classifying cases versus non-cases, running it through a pipeline and creating an analytic data set. Here's the first 30 or so terms alphabetically. They're in the dictionary. We manually created a dictionary with over 843 terms. A lot of them were about skin or mucosal concepts because those are important in diagnosing anaphylaxis. And the median chart had 128 concepts identified in it. It's another summary of the dictionary. And here, with the colors that are presented in the table, you can see we focus on key symptom groups. Reduced blood pressure is important, some gastrointestinal symptoms, respiratory compromise, and as I just mentioned, the skin or mucosal concepts. And we operationalized indicators for almost all of these concepts. We packaged this all into an NLP system, put it up on GitHub, and so we could apply the exact same NLP system in Kaiser Washington, where we developed this model, and then in our external validation set at Kaiser Northwest, where we got some external validation results. The code for getting the structured data was also part of this package. These are the 116 NLP covariates that we operationalized for this model. Many of them had to do with those concepts that you saw in the colored slide with the different symptom groups. We also had we had 30 NLP covariates that just captured the diagnostic criteria. For example, skin or mucosal involvement plus either respiratory compromise or reduced blood pressure. That is one of the criteria for clinically diagnosing anaphylaxis. Okay, so now the data have been assembled and we're ready to model it. We conducted two models. The first one looked at structured data only and labs. We did this because we wanted to compare and see if a model that relied only on structured data could be improved if we added a model that included the NLP covariates. And so we compared these two. The modeling, I won't go into much detail on the model. There were many different types of machine learned models. As you can see here on our next slide, we had 3 different data sets, 3 different covariate selection methods. There were 8 different models described here and in the paper. And then we also had a super learner model. So it was 75 different models that we tested in this data. These are the gold standard review results. Washington on the left, Northwest on the right. You can see down here at both sites, about 2/3 of the events that qualified were considered to be true anaphylaxis and the remainder not. You can also see here, we're training the data in Kaiser Washington. There were only 85, only 85 non-cases. And so this became the minority class that limited our ability to look at covariates in models. This slide presents our results. On the bottom here in the pink is the AUC for a structured data only model, AUC of 0.62. On the top here, there were two BART models that essentially perform the same. The one in blue, the second one also translated better to Kaiser Northwest. So that's the one we ultimately used for comparison. And then another that I won't go into here, a different set of covariates. The two Bayesian additive regression-free models performed best. As you just saw, the CVAUCs there were 0.7 at Washington. It degraded somewhat at Northwest, but not drastically, so we're encouraged by that. And then we used this model to classify each of the events, either cases or non-cases. Here we see the for the Kaiser Washington data, the risk scores across the horizontal axis here. And we see that if we were to say use a threshold where we would achieve 80% PPV, which is often a desirable level, we would get rather low sensitivity, the yellow line here. But we also see that there's this, PPV is relatively flat through a broad range of risk scores here, and while sensitivity drops off. So it may be more relevant, depending on your use case, to select a risk cut point for classifying cases. It's a bit lower on PPV to achieve a much higher sensitivity. So that's what we did. We took this model then and applied it exactly as curated at Washington to the Kaiser Northwest data, and here are the results. PPV at the external validation site was very similar. We do see a bit more degradation in sensitivity, but still not poor sensitivity. So the implications, the NLP-derived covariates did improve algorithm performance substantially, and machine learning models were well suited to this type of data. In our next steps, we're going to explore some other modeling. We're going to explore using all of the data to train and validate. And then we're also going to use some of those automated NLP approaches, a more heavily byte-focused approach that I mentioned. This is our study team and co-authors. And thank you for your attention, and I'm happy to answer any questions people may have.
Okay, thank you very much for a very nice presentation and very comprehensive analysis. So I think we have a few minutes for questions. Is there any questions from the floor? If not, may I ask one question? You suggest that in the future you might have like to do like a two-stage approach. Would you mind to give us more idea about this?
Yeah. Yes. Excuse me. So we're not doing it for anaphylaxis, but we're doing it for a different health outcome of interest in Sentinel, which is acute pancreatitis. We're using the exact same approach I presented here to develop a set of NLP-derived covariates and structured covariates and model them to classify people as to whether or not they really have acute pancreatitis. That work is almost done. As soon as we finish that, we're then going to take the same data set and apply some automated NLP development approaches that use, instead of the gold standard data for training and validation, we use silver standard data, which are things like, okay, among the patients who have acute pancreatitis, those with who within their records have many mentions of acute pancreatitis, or maybe multiple codes for acute pancreatitis, versus patients on the other end who have very few mentions of acute pancreatitis. Those would be our silver standard cases and our silver standard non-cases, and then use that silver standard to train a model. There's also automated approaches for building the dictionaries by mining information from knowledge base articles rather than, having clinicians and informaticists look at chart notes. And that work should be completed in 2022.
Okay. Thank you. And so-called Sadaguchi also asked about, she's surprised that AUC was only 0.7. Do you have any thoughts on why in this case?
Yeah, partly because, we couldn't consider as many covariates as we had hoped because of that. I mentioned this, the sample size was pretty generous, except that we only had 85 cases in our non-cases. So that's our minority class. So that really limited the number of covariates that we consider. Secondly, so that's one thing, the sample size issue, which the other thing was we didn't use any gold standard data to train the NLP system. And that's again, because we wanted to reserve it all for the model development phase. But with a larger sample size, we think there could be a better performance achieved. But then, it might be that anaphylaxis is just a very difficult one. The clinicians who reviewed the charts could agree 80% of the time that those charts were definitely anaphylaxis, but in 20% of the cases, they either disagreed and had to discuss it, or one or both of them said, this is a really hard call to make. And maybe they got it right, or maybe they disagreed, but they said it was a hard call to make. And so the upper limit on anaphylaxis might not be 100%.
Thank you very much. So I think time is up. So let me move to the next speaker. So the next speaker is Mary Ann Armstrong. The topic is validation of an algorithm to identify hormone contraceptive exposure in a large integrated healthcare delivery system database.
Can you see my screen?
Oh, yes.
Yes, can you see my screen?
Yes, very well.
Okay, great. Okay, let me change to slideshow. There we go. Okay, how's that? Can you hear me okay?
Yeah. But we still
great.
see the two panels, so you might need to switch.
Oh, you see the two panels?
Display setting. Yes, that's right. Yeah, that's right.
Okay, is it right now?
Yes, please go ahead. Thank you.
Okay, thanks. Sorry about that. Okay, so good morning. My name is Mary Ann Armstrong, and I'm a biostatistician and investigator at the Division of Research at Kaiser Permanente in Northern California. We're located in Oakland. I'd like to take this opportunity to acknowledge my co-authors, some of whom are from Kaiser Permanente in Northern California, including our PI listed at the bottom, Tina Rain Bennett. We also have members from Kaiser Permanente Southern California who are co-authors, as well as our colleague from Bayer International in Berlin, Germany. This project was funded by Bayer International with headquarters in Berlin, and we received an industry-sponsored grant from Bayer to conduct this project. So contraceptive use is an important indicator of women's reproductive health, but the accuracy of contraceptive surveillance using electronic health records has not been validated. Contraceptive use patterns over time can be extremely complex and difficult to capture, but accurate determination of contraceptive use time periods is important for assessing the association between specific contraceptive use and a variety of clinical outcomes. So the purpose of our study was to validate a new electronic algorithm developed to identify prescription hormonal contraceptive use periods in electronic health records for a study we were conducting of ectopic pregnancy and contraceptive use. The algorithm was based on a combination of diagnostic, procedural, and pharmacy dispensing codes
as well as natural language processing of clinical notes, and identified start and end dates of each contraceptive used by each woman over the study period. This slide shows the development of our validation cohort. So we began with the study population, which consisted of women aged 15 to 44 who were either Kaiser Permanente Northern or Southern California members during the study period from 2009 through 2019, and had 12 months of continuous membership prior to their index date. Now, the index date was defined as the first date a woman was a member of the Kaiser Permanente system during the study period, which started on January 1st, 2009, and also had 12 months of prior enrollment. So as you can see, our total N was about 3.5 million. I'm sorry, 3.4 million members from both Northern and Southern California combined. Next, to obtain the validation cohort, we first selected a random sample of 455 women from the population, stratified by the first contraceptive method they used during the study period. 15 women were excluded due to either no encounters during the study period or bad data, leaving us with a validation cohort of 440 women. The contraceptive types of interest were listed below here: levonorgestrel IUDs, copper IUDs, unknown IUD type, combined oral contraceptive pills, patches, and rings combined, progestin-only oral contraceptive pills, depomedroxyprogesterone acetate or DMPA injections, and contraceptive implants. We also looked at the category of no prescription methods used during the study period. So the validation cohort stratification scheme was as follows. 25% of the validation cohort used no method at any time during the study period. 15% used LNG IUDs, and another 15% used the combined oral contraceptive pills. 10% used copper IUDs, another 10% implants, and another 10% progestin-only oral contraceptive pills. And finally, 5% were unknown IUD type, patches and rings, or DMPA. So the purpose of the algorithm was to determine contraceptive exposure time, primarily based on EHR evidence of time from start to discontinuation of each method. When there were multiple periods of use, the determination of the exposure could be very complex. So I'd like to show you an example of one of these complex situations so you get an idea of what I'm talking about. Hopefully you can see this well enough. So this is a woman who was enrolled in the health plan in January of 2006 and was a member, so it's already a member with 12 months of membership prior to the first possible index date, which was January 1st, 2009. Remember, that's the start date of the study, so that's the first possible index date. So the different colors here represent different types of use periods. So the sort of pinkish purplish color represents non-use periods. So that means the woman was not using a contraceptive method during this first period after her index date. Then she started using a copper IUD at this date, and that went on through here, as you can see by the bracket here. But her second method, patch or ring, started here and continued through there. So you can see we have an overlap period in this gray area here. And so we had to develop a hierarchy of methods to provide rules for which method to choose in that type of situation. So as this woman's history progressed, after the patch and ring, she again had a period of no use. Oops, sorry. At which point she here had an ectopic pregnancy, which, as I mentioned, was what we were focusing on for our study. And that led to a temporary censoring period during that time. That was followed by another period of non-use and a pregnancy, and so on through another 2 methods until she left the health plan in 2014. So I think that gives you an idea of how complicated this data can be and how complicated the algorithm was ultimately. So back to the algorithm, the pharmacy databases only provide information about dispensing dates and dispensing dates and days supply of each prescription dispensed. So we had to make assumptions about the initiation of dispensed drugs in order to approximate each patient's actual use. For example, we allowed a 14-day gap between the dispensing dates of 2 prescriptions to allow for initiation of the use of the first prescription after the dispense date rather than on the dispense date. For implants and IUDs, when possible, the start and stop dates were determined using codes such as relevant ICD-9 and 10 codes, current procedural terminology codes, CPT codes, or medication codes such as National Drug or KP specific codes. But sometimes codes are not always adequate to identify these two methods. Sometimes the start of use may have occurred before the woman joined Kaiser Permanente. In that case, we would have to look for surveillance or removal codes to see if she was in fact using an IUD. We also would look at NLP of the EHR clinical notes used to identify IUD removals when there were no codes for removals or any other codes available. So for the validation, up to 5 periods of use were identified by the algorithm per woman. Trained chart abstractors conducted manual chart review of the EHRs of each woman to verify the contraceptive use periods identified by the algorithm. And then the algorithm and chart review results were compared. So for the analysis, first summary statistics were calculated for demographics, and then the accuracy of the electronic algorithm that was developed was assessed against the gold standard, which was the manual chart review. And we did this by estimating the positive predictive value, which in this case would be the number of use periods confirmed by the chart review divided by the total number of contraceptive use periods for that particular woman. So positive predictive value was calculated overall and by method. So here are the results. Next 3 slides look at the characteristics of the population and the validation sample. So compared to the study population, the validation cohort was slightly younger, about 65% under 30 versus about 57% under 30. But they had a similar race and ethnicity distribution, as well as similar median census block family household income distributions. And as one would expect, due to the stratified random sampling scheme by contraceptive method, the distribution of the validation cohort for contraceptive method is just similar to the one for the population distribution. Okay, and here are the results of the accuracy of the electronic algorithm compared to the chart review by method and overall. So first of all, for overall, there were a total of 709 periods of use that were reviewed. That includes the no prescription method used category. And of those, 659 were confirmed by the chart review. So that gives us a positive predictive value of 93%. When we look at it by method, the highest is copper IUD with a positive predictive value of 100%. For the other methods, the positive predictive values vary from the 90s to the high 80s, with the exception of implants, which had a positive predictive value of about 84%. For the category of no prescription method use, there were 104 periods reviewed, non-use periods reviewed, and of those, 101 were confirmed by the chart review for a 97% positive predictive value. So the strengths of our study include the use of natural language processing to improve accuracy, the large diverse cohort in each contraceptive use category, and the long enrollment in KP provide the ability to validate periods of methods used despite their complex use patterns. Our limitation really is primarily the lack of data for care received prior to joining KP. So as I alluded to, we assumed that women who had contraceptive device removal codes or contraceptive surveillance codes, but no insertion codes at Kaiser Permanente, we assume that they entered the health plan with that device already in place. So in conclusion, the algorithm that we developed, we found that the validation showed that the algorithm was very accurate and provides a useful tool for future pharmacoepidemiologic studies. Thank you very much.
Thank you very much for a very nice presentation. So I think we have a few minutes for a question. Any question from the floor? Oh, I found one question from the QA box. Did you test in algorithms without NLP portion, say only structures data.
I'm sorry, I couldn't quite understand what you said.
Sorry. One question is about, did you test an algorithm without NLP portion? That is to say, only structured data.
I'm sorry, I'm still not quite getting what you're asking. I'm trying to open the chat. I'm having trouble finding it.
Yeah, I think the question is about, have you tried? Yeah. Could you hear me well?
Yeah, I'm trying to open the chat so I can read the question.
Okay. Okay.
Except I don't see a question for me in the chat.
The question is, did you test an algorithm without NLP portion, i.e. only structured data?
Oh, no, we did not.
Okay. So is there any other question? Let me check the QA box.
I don't see any.
Okay, so if no, Shabir, do you have any comment or any things you'd like to add?
No, I don't have any questions or remarks myself.
Could you remind me, when should we close the section?
We still have 14 more minutes, but it's fine to finish early if there are no more questions or comments.
Good. So let me check once again if there are any questions. So if no, thank you very much for the very nice presentation. Thank you. So I think we have already completed all the presentation. So we are gonna close today's this section. Shabir, do you want to say anything?
No, yes, I would like to thank all the presenters for all these wonderful presentations. Remind the assistants that this session has been recorded and it's accessible from the ICPE website. And yeah, that's all from my side. Thank you, everyone.
Thank you, everyone. So I'll see you next year. Thank you. Bye-bye.